Good afternoon and welcome to Independent Sage. Here we are on another Friday, but it's a nice day. So today's session is going to be on vulnerability, and we've got quite a lot to cover. The COVID-19 pandemic, as we know, hit us all. We were all facing the same storm, but we became very acutely aware right from the beginning that although we were all facing the same storm, we weren't all in the same boat. And that was particularly the case for clinically vulnerable people who we realized were at a much higher risk of infection, a higher risk of serious illness, and more devastatingly, a higher risk of death. Now, the only problem is while the pandemic has worn on and many of us have gone back to so-called normal lives, it's not been the same for everybody. And of course, it's definitely not been the same for clinically vulnerable people. So today, we're going to be covering that issue of how is it for clinically vulnerable people? How are they getting on in their lives? What are their stories? How do they feel vulnerable? And what are the issues that really matter? The important thing here is we need to remember that not only are clinically vulnerable people at risk of COVID, but those very patients, those very people, those with respiratory issues, autoimmune conditions, and even those who have cancer, not only are they vulnerable to COVID, but their very illnesses that they have also been disrupted from the pandemic. So today we're going to hear about that with Dr. Lennard leading on that discussion. And we've got three fantastic guests to help us to understand their stories, to understand what's going on. Hopefully by the end of it, we'll be able to learn a bit more about how we should be thinking about designing a social and health infrastructure that not only benefits clinically vulnerable people, but benefits us all. Now, before we go to that, as always, we have our exciting numbers section with our amazing Professor Christina Pagel, who hopefully has a presentation for us. Christina, over to you.
Thank you. Right, let me share my screen. So I'm going to try and cover quite a lot, but hopefully reasonably fast. So vaccines, hospitalizations and deaths, just the latest variant picture, a little bit on what respiratory infections are around at the moment. Just going to bring back a blast from the past and look at a couple of other countries. And then the latest NHS indicators have come out. I think as we go into winter, it's important to look at those. And then just some slides kind of setting the context for today's session on clinically vulnerable people. Right, so I'm going to start with vaccines, and really the autumn booster campaign is now well underway, but it has, as you can see, looks like we're plateauing at about 50% overall uptake among eligible groups in England. If we look at it just by uptake in the over 65, so just for people who are eligible because of age across the different nations, it's a little higher, highest in England at 68% and lowest in Wales at 50%. But if we compare it to last year's booster campaign and where we were around the same time, you can see the uptake this year has been lower for all nations. The biggest difference is Scotland, where they had 81% uptake in the over 65s last year and really at 60% this year. So we are seeing a drop off in uptake. And we're also seeing, as we've seen throughout the pandemic, and it really isn't getting any better, a significant difference by deprivation in the uptake of vaccination. So looking at hospitalizations and deaths, it's good news this week in that hospitalizations in England with COVID have been falling steadily for the last 3 weeks or so. This is good news. We're seeing a similar pattern in Scotland. And the reason I want to look at Scotland is because they also have wastewater monitoring. So blue is hospitalizations, and you can see they're falling over the last few weeks. And you can see that this is the wastewater in the maroon. They had 2 spikes in autumn, but that's now coming down too. So it suggests that we are genuinely in a dip at the moment, which is good. Who knows if it will go up again before Christmas, but if not, that's really good news for the NHS. And And I just want to highlight one thing, and this is hospitalizations in children per population, and separated out into under sixes, so 0 to 5-year-olds and 6 to 17-year-olds. And this is since the beginning of the pandemic. And you can see this was Omicron, those 3 big waves of Omicron, which really hit well, everyone hard, but particularly the under 5s had really high admissions then. But effectively in 2023, we're still seeing high admissions in this age group relative to previously. So you can see that really they're still seeing levels that are as high or higher than they've been throughout the pandemic, apart from that first Omicron year, compared to 6 to 17-year-olds and actually adults, where we're seeing admissions that are now lower than they were in the early pandemic. So for the under 5s, it's still kind of mid-pandemic. The number of deaths with COVID is in England is plateauing. It will come down over the next few weeks following infections. And we're seeing a very similar pattern in both Scotland and Northern Ireland as well. Just one slide on variants, which is that there's not much to see here. This is the latest data from UKHSA up to the 12th of November. All of these colours here are different types of Omicron XBB. That's kind of been dominant in England for, I guess, 9-10 months now, with various varieties. This purple patch at the bottom is that new variant that popped up in August called BA.2.86, which is very different to all the other variants, also called Pirola. It's growing, it's not growing as fast as people are worried about. And so that we should take that as good news. In terms of respiratory viruses in general, this is from the UKHSA at the moment. So most common is from positivity tests is rhinovirus, which causes cold, and then RSV, which is particularly seen in kids in schools, although they're also the ones that get tested, so it's not entirely clear. But basically, if you have cold-like symptoms, it's probably one of those two, but it could still very easily be COVID. So please do keep testing. Flu is still very low at the moment. Just a picture showing you COVID hospitalizations and flu for the last 6 years. And just to show you that whatever COVID is, it's not flu. But I think we do want to look at flu, so compare it to last year. So last year we had a really big spike. This is the flu admissions in 2022. This is the last kind of pre-pandemic year. This is 2020, this is 2018. And this is where we are on this red line. So at the moment, if anything, we're tracking these years down here. So if we can avoid the spike that we had last year, that's really good news for the NHS and obviously good news for patients as well. So I think in the next kind of 4 weeks will really kind of show us what kind of trajectory we're on there. Internationally, now I just want to highlight just a couple of things just to show that COVID can still surprise us. This is that Finland and Sweden are both seeing really big increases at the moment, but it's not due to a new variant. They seem to have very similar variant makeup to the UK and other European countries. So it's not really quite clear what's driving it. But this is wastewater monitoring in Finland, and you can see that it's been a really rapid increase just over the last few weeks. And this is wastewater monitoring in Sweden. This is by different districts, but you can see a couple of their districts are really going through the roof. And you're seeing this also reflected in hospital admissions. So this is Finnish hospital admissions due to COVID, which is how they record it. And you can see there's a really big, steep spike over the last couple of months. This is over the whole pandemic. So you can see it really is quite a significant number of admissions. And in Sweden, you're also seeing quite a significant increase in hospital admissions this time with COVID. So there's clearly something happening in those countries. We don't really know why, but so I think it's just to kind of show that COVID still can easily have a sting in the tail. So NHS key performance indicators were published this week. And effectively what's happening is that in the emergency services, things are not looking great. So this is just an example for response times for ambulance calls. This is C2 calls, which are not immediately life-threatening, but very serious, such as stroke or chest pain. which may become life-threatening. The target is 18 minutes response. We've not reached that since 2021. But you can see that after recovery this summer, after last winter, we are now seeing sustained increases, and it's now at 40 minutes. So it's over twice as long as it should be to respond to these calls, which is really quite an issue. And now we're just starting the winter period as well. We're seeing it also reflected in A&E. This is the percentage of A&E patients waiting longer than 4 hours from arrival to admission. It's hit 30% again. You can see it's historically much, much higher than it's been since ever. And if we look at it just by year, the red line is this year, 2022, which is really the year that things went horribly wrong last year in emergency care. We're kind of tracking that much more than we're tracking 2021, and we're nowhere near where we were pre-pandemic. So this is quite worrying. What might help is if we don't see the same kind of flu spike that we had last year. But we are seeing things like extremely long waits in A&E starting to really kick up again. And again, this is not good news. In terms of general delays in other bits of the system, we're continuing to see really high numbers of referrals for treatment, 7.7 million. For the first time, NHS actually equated that into people waiting. So 6.5 million people are waiting for treatment because some are waiting for more than one thing, which is really a massive number. And we're just not making inroads into that backlog. And these kind of delays are affecting cancer treatments, as an example. So this is people waiting more than 2 weeks to see a consultant following an urgent referral. And you can see that that's gone back up to 25%. Target is 7%. So just to finish on just looking at some data that we have on clinically vulnerable people. So firstly, they are clinically vulnerable, and they're called clinically vulnerable for a reason, and that's that they are more vulnerable to severe disease and death. So it's 4% of the population, but make up a much higher proportion of hospital admissions. Almost 30% of all ICU admissions are clinically vulnerable for COVID, and 24% of all deaths with COVID. So it is a vulnerable population to COVID. And there's also data that just about a year and a half ago that ONS survey did on clinically vulnerable people, asking them about the impact of the pandemic. So the first question is, overall, how much of an impact has the pandemic had upon you? And you can see that the vast majority were either very negative or slightly negative impact. They asked whether the pandemic poses a risk to physical or mental health. Again, almost all of them said yes, it was a significant risk for their physical health, and actually quite a lot also for their mental health. They asked how sufficient current government advice was. If anything, it's got less since April 2022. And really, 2/3 of people were either don't know or not sufficient. And I thought these were quite interesting questions. So compared to pre-pandemic times, how likely are you to travel for leisure? And you can see that, again, the vast majority were less likely to travel for leisure, either within the UK or abroad. And actually, traveling for work, you see the same pattern of people being less likely to travel. So many clinically vulnerable people are not in work, so that's these kind of grey bars, but for the ones that are, they're less likely to travel. So you can see that these kinds of limitations really affect people's social lives, but also affect their working lives and ability to progress there. We also have this data from the group clinically vulnerable families, showing that 91% of clinically vulnerable people would or have delayed or cancelled medical appointments due to high COVID risks. And this was, again, a survey taken a year ago. But this is extremely high and obviously not great if people feel they can't access healthcare safely. And just the final slide, just to show you the impacts of long COVID. So this is long COVID in people who are otherwise not limited by health conditions. And you can see that very few of them actually report to being impacted a lot by their long COVID symptoms. If you look at that compared to people who say their daily activity is limited a lot by health conditions, so which would be a big overlap with the clinically vulnerable or not an exact one-to-one relationship, you can see here that long COVID tends to be much more severe in people who have other health conditions going on. And 7% of them are saying that long COVID limits their activity a lot. So just to summarise, autumn boosters are underway for the over 65s and immunocompromised, but there is a drop-off in uptake compared to last year, and it's plateauing at around 50% overall uptake in England. COVID hospitalizations are falling steadily, and deaths should be falling over the coming weeks. The first COVID infection survey results are due early December. So that's when we'll get our first real idea of what prevalence is in the UK. The NHS is very stretched getting into winter, and we're already seeing the performance indicators going the wrong way, and they're far too similar to last year's disaster for my peace of mind. However, we aren't seeing much flu activity at the moment. So if we get situations, because last year flu, COVID, RSV all peaked really high in December, if we don't see that, then that will really, really help reduce the impact of winter on the NHS. And just finally, the clinically vulnerable are at significantly higher risk of more severe COVID disease, and their lives have been and remain more affected. And I will stop there.
Thanks so much, Christina. There's a lot there for us to think about. And just for a minute, I do want to go over some of those issues around clinically vulnerable people, starting from children, starting from the under 5s, and how we've still got higher admission rates for the under 5s. You know, it's not, whenever we think of clinically vulnerable people, we tend to think about much older people. We forget that there are also vulnerable groups among children who, of course, remain under-vaccinated, including unvaccinated. So something for us to think about. I think the other really stark figures that Professor Pagel shared with us is around how smaller group clinically vulnerable people are, to one extent, in terms of representing 3.9% of the population. But then when you look at their risk in terms of hospital admissions, ICU admissions, and more tragically, among deaths, it is significantly higher. So that's something to think about as well. And of course, those really stark graphs around how because of the pandemic, because measures haven't been taken to reduce the prevalence of COVID, to take measures to ensure that ventilation and other things around people, clinically vulnerable people, are still, their mental health is affected, their physical health is affected. And this is the really important thing that Christina said, I thought, which is that 91% of people surveyed in a recent survey said that they would avoid much necessary and important medical appointments because they're so afraid of getting COVID. Now, today, to discuss this all, we have three incredible guests joining us. We have Sarah Stephen, Professor Martin Paul Eve, and Dr. Mark Yates. And our very own Dr. Lennard Lee will be hosting that session. Lennard, over to you.
Thanks, Zubaida, and thanks, Christina. I really find this data fascinating. Christina is so clear, and this is really helpful just before on in terms of data. So we're really lucky today to have three of the most impressive people. I think you're going to find this really interesting 20 minutes. I would say these are the best people in the country. We've got Dr. Mark Yates, Sarah, and Martin. And I think their stories, what they've learned in the last 3 years is fascinating. I do think you will maybe leave the session feeling just a bit impressed by what they've done, but also clear in terms of what needs to happen next. So let's start off. Dr. Mark Yates is up first. He's a clinical academic, a medical doctor, a data scientist, and also rheumatologist. Mark, welcome. I think the first thing I'd ask you is, some people would say that data doesn't matter. We don't need data. What's your view about that?
Thanks, Len. Well, I think it's been illustrated very well in the slides that we've just seen that the data is so important and crucial to allowing us to have a handle on a societal level, but also on a personal level. And I think when we apply that to the context of risk in clinically vulnerable people, that becomes even more important. And one thing that we've seen over the course of the pandemic is our perception and how we perceive risk and how risk is accounted for has changed. Going from a period where everyone was kind of thrown into one boat as being everybody was at risk, and how that's evolved as we've stepped out of the acute period of the pandemic. And we're seeing this persistent risk in clinically vulnerable people. And without the underlying data, you don't have that information that can inform people's behaviours and also government policy.
Thanks, Mark. I think it's kind of interesting what you say there about we all start off in the same boat, but there are other people which are still being affected. You did something quite special, didn't you, Mark? You pulled together quite an amazing team and delivered the research with them. It's called the Inform Study. Can you tell us more? Because we got a bit of a snippet earlier on today.
Yeah, so the Inform Study is a study that's using data from NHS England, where essentially we wanted to understand the risk of severe COVID-19 outcomes in clinically vulnerable individuals. And in order to do that with enough certainty and surety in the results, you need a really big population of people, because otherwise the methods and the tests just don't work properly. So we have a sample or a population of about 13 million people in England. And using that information, we were able to look at the risk of hospitalization, intensive care admission, and death in clinically vulnerable individuals. And really the headline finding is that the clinically vulnerable or immunocompromised population accounts for about 4 in 100 people in England. But that group accounts for 22 in 100 of COVID-19 hospitalizations, with similar numbers for intensive care admissions and for deaths. And we took that a step further as well, as we also wanted to make sure that there weren't other things that were having an impact on the risk of hospitalization and intensive care and death. So we also ran analyses where we took account of people's age and their sex and their other risk factors, so other conditions that they might have, like heart disease or diabetes. And we saw that the risk was still increased in this group, which really does underline what we were saying, that there's a group in our population that have an ongoing burden of COVID that isn't shared with the rest of society.
Mark, thanks very much. I think that's just so impressive what you pulled together. Thank you so much for doing that for the country. 30 million is a lot of people, and to put out those risks were just fantastic. Congratulations on your Lancet paper. So I think I want to try and move the discussion on now, because we're also joined here by Dr. Martin Eves. So he's a British academic, he's a computer programmer, but actually most importantly, he's also a great disability rights campaigner. So Martin, I'm just really interested. You've heard the data, it's UK data. What's your reaction?
Thanks, Lennard. So I have a set of serious immune suppressing conditions. I'm a kidney failure patient on dialysis. I have rheumatoid arthritis, which I'm given biological immunosuppressants, and I have secondary immunodeficiency that requires treatment with immunoglobulins. So I'm one of the people in the very extremely clinically vulnerable category with 3 different immune suppressing conditions. This bore out when I got COVID last January, which I got while traveling to a routine hospital appointment. I was hospitalized for over a month in the serious infectious diseases ward, despite multiple, I think 5 doses of vaccine. So what's clear from this is that the pandemic is only over for most people. For people with conditions like mine, dubbed vulnerable, there's still, as we've seen in the data just presented, a huge level of risk of serious illness and death. Now, I'd assumed that even with such disparate outcomes, society in the UK would be caring enough to protect the most vulnerable. Instead, what I've seen is people becoming willing to risk the health and safety, that is, the lives of the most vulnerable, in order just to pretend that nothing has changed for anybody. The tyranny of the majority is emblematized for me by people in hospitals, for example, places where the absolute most vulnerable have no choice but to travel, deciding that they don't want to wear masks. And I guess this was always the problem with COVID, as we've mentioned. For some people, it seems just like a cold. For others, it's a death sentence. And rather than take the precautionary principle, protecting those for whom it's lethal, the UK government decided to protect the freedom not to care of those for whom it was mild.
Thanks. I think Martin may have cut out, but I mean, that's pretty hard-hitting stuff. Martin, you back?
Yeah, I'm back. Sorry. I don't know what's going on there. Apologies for that. Can you hear me now?
Yes, we can. So Martin, I think you've clearly been affected. You got COVID on the way to the hospital, which is not great, and it's affected you quite in many ways. I was wondering if you could tell us what you feel you can do and can't do, and how's it affecting you now? Because as you say, for many, like myself, we've almost been able to go back to near normal lives. How is it for you?
So at peak infectivity levels, we totally shielded. Nobody could visit us without 10 days of isolation beforehand. We didn't go anywhere or see anyone. Public transport was definitely off the cards. And when we did see people, we'd meet them outside. We've since relaxed this slightly, reducing the time that people isolate for before they visit, but we still have quite a strict regime in order to protect me. As we've already mentioned, there have been various studies into mental health implications of protracted shielding. So Jo Daniels and her group at Bath University, for instance, have conducted research over the course of the pandemic, which repeatedly demonstrate that those who are shielding experience significantly higher levels of anxiety and psychological distress in comparison to the general public. We here in my household have been in this state for almost 4 years now, and it's totally transformed our lives for the much worse. Facebook memories of how we used to travel now become bitter reminders of those risks we can't take. But I guess what's worse than the formal shielding was the withdrawal of formal shielding. Vulnerable people were told that suddenly, apparently, the threat that had been so severe that they had to hide away had just disappeared overnight. It was now going to be up to us individually to judge our appetite risk, in quotation marks. Well, I can tell you, my appetite for dying in exchange for normal routine things like a neighbour's barbecue party is not high. And so we've been left in limbo, but it's why these data are so important. How are we to judge individual risk unless we can get a picture of what's actually going on?
Well, thanks, Martin. Yeah, you made a really strong point there about trying to balance your personal risk yourself, and it's not easy. I'd like to bring in Sarah now. So Sarah is a fantastic person because she's made amazing change happen too. You're a patient champion, you're a health campaigner, you're an advocate for the clinical vulnerable families, and she's also a West End actress, or wasn't a West End actress, so an amazing person. Sarah, I can see you nodding quite a lot there, and when you hear the story, bring it back to the patient level now, away from numbers, back to patients. I mean, I think you had a difficult time during the pandemic. Did you want to tell us a bit more about what you went through?
Yeah, well, I didn't start the pandemic as immune compromised. I was a fit, healthy person. I was a jobbing actress, worked in theatre, little bits of telly here and there. And then my industry shut down in March. And then by the time it reopened in the autumn, I'd been diagnosed with breast cancer. It was early stage, but it was aggressive. So I had to get into treatment straight away. So I was straight into chemo. I had 21 rounds of immunotherapy and chemotherapy in total. That lasted 1.5 years. I also had 2 surgeries, 20 sessions of radiotherapy. So basically, my body was completely hammered. And I went from being this healthy person who was protecting the vulnerable to being immunocompromised myself overnight. So I've had both experiences. It was terrifying, really. And we were told to shield. My husband and I were both self-employed. He's a builder, so neither of us could work from home. And we had savings, so we couldn't get any benefits, and we had no money coming in.
Goodness, Sarah, that was difficult. I think when we think about vulnerability during the pandemic, as Zubaida says, we tend to think about it, say, an older patient. But actually, the thing that strikes me both about you and Martin is that you are young, you are in the middle of life, and it being immunocompromised can affect so many people. And Sarah, I think one of the things that I heard about was that it's your role as a patient champion, because you've changed the healthcare system, haven't you? I'm interested if you could tell us a bit more. Tell us what you did and how you did it, because it's very impressive.
Well, I don't think I changed the healthcare system, but I do think I challenged the system enough to get the management of the NHS Trust to start thinking about how they were treating their immunocompromised patients. Basically, when Freedom Day, that instills fear into me when I hear it. When Freedom Day happened, which was the 19th of July, 21, I was, that very same week, I'd started my 20 rounds of radiotherapy. So I was in hospital 5 times a week, and my husband had to go back to work that same week because we'd just run out of money. And so he was staying in my neighbour's caravan in their garden in order to keep me safe. So I was driving myself, nearly a 3-hour round trip to radiotherapy every day, 5 days a week, and he was living in the caravan. It was a pretty crappy summer. And I was really scared because at night I used to see pictures on the news of people going back to 2019 life, you know, they were all out in restaurants, pubs, and this Freedom Day mindset, I noticed started to bleed into the chemotherapy unit. Patients weren't wearing masks like they had done, and the staff themselves were saying, you'll be fine, we've all had our vaccines. And it was this attitude that it was okay, and I just felt it wasn't okay. So I raised it with the hospital management. I made loads of noise. Eventually I managed to get a few meetings. I had a meeting with the CEO of the trust. He passed me on to the NHS, to the Infection Prevention Control Department, and I managed to get some HEPA filters put into the chemo unit. But that's just one hospital and one chemo unit. And I feel like there were lots of other things I wanted to change and I couldn't on my own. So that's when I joined Clinically Vulnerable Families, because I contacted them for support, but then I discovered that they were quite keen campaigners, and I found other people who were also angry and frightened. And it was that anger that prompted me into doing something, really, because I just thought, I need to change this. This can't be right. We cannot cope with this as a society. So joining CVF was really important. I discovered that I had it easy, actually. I may have been immune compromised, but I didn't have kids. And these people, these families had kids in school, and they were being threatened with prosecutions and fines for sending for wanting to keep their vulnerable children away from school, or their children didn't want to go into school and come home and kill mum and dad. You know, it got to that stage. And so now I feel like we've got a really powerful voice in CVF, and so much so that we're now the only group representing the clinically vulnerable in the COVID inquiry.
Thank you, Sarah. I mean, I think it clearly was very scary, and I think there's lots of patients groups out there, and you all do so much. And Martin's also part of that too. So fantastic. Thank you very much. Just very impressive and inspiring. Just showing you really why it does matter to try and make sure we've got infection control sorted, that it's not it's going to cause issues to people going forward, but people are still being affected. So I'm going to bring this back to everyone now in the final few minutes. I guess it's not in the news as much as you wanted. COVID-19 has reduced in terms of headlines at the moment, but we still hear a lot about the COVID inquiry, and I guess it's important because we allow ourselves to learn, to get better. So if this ever happens again, people like us will be able to make sure that we have a better experience for everyone. So going round now, I was keen to ask you guys, what stuck out for you about the COVID-19 inquiry? What did you learn, or what did you make of it? I'll go back to Mark first.
Thanks, Len. I think probably the main headline for me is that at times it appeared that decision-making was being conducted that wasn't evidence-based or data-driven. And I think given obviously the importance of the decisions that were being made and the amount of data that was available from quite early in the pandemic, I think that's something that really could be learned from. Is the vast majority of decisions should have been data-driven, and I think if we could go back in time, we would all hope that would be done more thoroughly and more robustly with an evidence-based, data-driven policy.
Thanks, Mark. And you've been pushing that, and I think we all stand behind you in that need to have data, and so we can understand risk. Thank you, Mark. Martin, how about you?
I think I'd put it a bit more strongly than that. And for me, what really sticks out is the almost eugenicist abrogation of public health leadership that's coming through here. I mean, what kind of government says, oh, well, we won't bother fighting it as this disease is nature's way of killing off the disabled, the vulnerable and the elderly? Clearly, unfortunately, it was the government that we had. And it just seems to me that if we were to learn anything future pandemics should be managed on the basis that we can do things about these events. They're not just something that happens and bad luck if you fall into these categories. We expect our leaders to work out how to protect the most vulnerable in society.
Well, wasn't expecting you to go that strong, Martin, but clearly it's a very difficult decision for everyone. And yeah, I guess that's definitely a viewpoint, and I can see why that would be difficult for many people involved. Sarah.
Well, I've been following the inquiry really closely because I'm part of Clinically Vulnerable Families Inquiry Feedback Team. So the most striking thing for us at the moment is that although we are core participants in the inquiry as a group, and we're giving evidence next year in modules 3 and 4, which are vaccines and therapeutics and healthcare, the problem is we're on module 2 right now, and that is happening at the moment. And the clinically vulnerable have not got a voice in that room because we were rejected for that module. But this module deals with shielding and segmentation or segregation or apartheid or whatever you want to call it. But we don't have a comment on that. And that's quite alarming. So it's really important that if you're clinically vulnerable, you have your voice heard. You can go to Every Story Matters on the UK Inquiry website and log your story with them. It will make a difference. It will help contribute towards the evidence, especially right now with shielding. It's really important. And also, please come and join us at Clinically Vulnerable Families. You can find us on Facebook. We are an amplified voice because there are a lot of us, and we're growing, sadly, as time goes on. So please come and join us, and we can make lots of noise together, and you're not on your own.
Well, thank you everyone for all your testimonies and feedback. It was very powerful. I think at Independent Sage, what we're trying to do here is help get these lessons out there, get people's voices and learn from it, because nothing is done perfectly. Lots of things were done on the fly, difficult situations, but I'll pass back to Zubaida to carry on.
Thank you, Lennard. Thank you so much. That was an incredibly powerful discussion. Thanks, Sarah, Martin, and Mark. It was really, really helpful and powerful to hear your research, but also your lived experiences, which I think brought home very powerfully the notion that Freedom Day was an illusion, that Freedom Day was actually just for a very few in this country, and it completely and utterly ignored the freedom of not just clinically vulnerable people like yourselves, but your families, your carers, surrounding groups, young people who have not been vaccinated. So I think you raised some really important issues there. And we heard, of course, about how clinically vulnerable people, as Mark was saying, represent a small part of the population, but their risk is significantly higher, 5 to 6 times higher in terms of hospitalization, severe illness, and death. We've heard also from Martin how for some people, COVID is like getting a cold, but for others, it's like a death sentence. And we heard from Sarah her extraordinary and difficult journey. And yet, Sarah had time. Sarah had time to take up a fight, a really important fight with her hospital in terms of putting HEPA filters in chemo units. You would have thought that'd be really obvious. Anyway, thank you. Thank you, an incredible discussion. Right, we now move to our really, really great, very exciting question and answer session. And we have some guests with us today. So without any further ado, Katie Ewing, are you there to ask your question?
Hi there, can you hear me?
Yes, we can.
Thanks so much for having me. Yeah, so firstly, my email said I'm really so disappointed that these are ending, but I just wanted you all to know that you've really helped to keep me afloat this whole time. Having Independent Sage there has just been life-saving. So my question is that up until March this year, I was in a group which the NHS website stated, quote, continue to be at high risk from COVID-19 despite vaccination. And then that web page was removed, and now there is only guidance for people whose immune system means that they are at higher risk. So I'm not immunocompromised, but I am in the Green Book chapter 14a table 3 and was lucky enough to be eligible for the autumn booster. So I have chronic neurological disease. And the Scottish COVID guidance is, I think, even harsher in a sense that the Scottish guidance states that the COVID-19 highest risk list ended on 31st of May 2022. The success of the vaccination programme and the availability of new medicines to treat COVID-19 mean that the majority of people on the list are at no greater risk from COVID-19 than the general population. So my question is, has something actually changed about the virus since spring that means that it is less dangerous to people in this group? Or have studies shown that people like me are no longer at higher risk than the general population despite vaccination? And I suspect that neither are true because I am in that Green Book table and I was vaccinated, but I'd just love to hear what you think about that.
What a fantastic question. Thank you, Katie. Right, do we have any offers to answer that question? Professor Steve Griffin, I saw you nodding. Would you like to start on this one?
Yes, and first I should just say, Katie, it must just feel so dreadful to be, well, frankly, gaslighted by that sort of legislation. No, the virus has not lost any virulence, and remember, disease is a function of the virulence of the virus and your immunity and your environment. So having underlying conditions is always going to complicate things. It is true that vulnerable people can sometimes generate better protection the more vaccines they have, but there is a limit to that. And this virus remains very, very capable, as we've been hearing, of causing quite profound disease. So I really don't know what evidence that assertion's been made upon. And just one last quick point regarding the treatments that we have available. Well, actually, those have been whittled down to just one agent practically now for the prevention of severe COVID, and that's the Paxlovid drug from Pfizer. The availability of the others is limited because there's various reviews going on, and the number of monoclonal antibodies that we can have available now is extremely limited because the virus is outpacing it in terms of evolution, and they're just not making more. So I think that the promises made in the living with strategies are not being upheld now, and I think that clinically vulnerable groups have every right to campaign for more to be done on their behalf.
Thank you very much. Would anybody else like to come in here? I mean, one of the things I was thinking about what Katie was saying is, I don't know if you remember, but at the beginning of the pandemic, the clinically vulnerable group, as defined by the government, were much bigger than in the middle of the pandemic when they suddenly became redefined and became a much smaller group. Does anybody want to comment on that? Sarah, would you like to come in here?
Yeah, well, I didn't want to comment on that specifically, but what I did want to say to Katie is that in CVF, we are, as I said, in modules 3 and 4 next year in the inquiry, and that is dealing with vaccines and therapeutics. I think that's module 3 or 4. And we are feeding to our lawyers all the time information about the clinically vulnerable, and that will help form the questioning in the inquiry in the room. Now, I know that doesn't help you now. I know that doesn't help you get your life back on track right now, but you just need to know that there's work being done all the time underneath everything to try and get them to recognise the plight that we all have. So please get in touch with CVF, Clinically Vulnerable Families, on Facebook, and let us know your story, and we can help use that to feed to our lawyers. It's really, really important. It's our one chance to get our voice heard at the moment.
Thank you. Very quickly, I'm going to come to you, Professor Sheena Cruikshank, but Sarah, can you just remind the audience who you represent, please? So
we are called, it's a mouthful, Clinically Vulnerable Families. You can find us on social media. You can find us on Facebook and on Twitter. I'd advise finding us on Facebook first.
Thank you very much. Professor Cruikshank, would you like to come?
I think, well, I mean, I've already talked a few times now about the sort of decision-making around vaccine access and how it's changed, and how it's really focusing on quite narrow questions about hospitalisation and fatality around decision-making for cost benefit analysis is the words they use, not me, for who gets the vaccine. But I think it is a really important point about why are these things changing? What is the evidence base for that? But also what you're saying about access to drugs. As Steve's just said, we have a limited pool of drugs here in the UK that we're able to offer people at the moment. And what's really struck me, I've been lucky enough to work with clinically vulnerable families, is the logistics and legislation that holds up trials and holds up, well, not so much the trials, but decision making about what drugs will be allowed to be used by whom and when. And I think that then filters down so that we've got another secondary issue where some clinical people are unsure what drugs, what categories they can give them to. And that's because I think the information isn't very clear cut. And that means you can get into this awful situation where you've got to be just the right level of ill to get them, i.e. not so mild that people think, oh, he's okay or she's okay, but not so sick that it's going to be too late to make a difference. And that is not a good scenario. We need really clear guidance. And I think that's the take home that we should be taking. We should have much more agile ways of approving drugs and getting them out to people. But the good news is there's just been a new paper called the Moonshot Trial, which has identified a brand new sort of way to look and discover new antivirals. So we can do it. We can find new drugs.
Thank you. Thank you very much. Very passionately there. That's what I like to hear. Right. Now we have another fantastic guest who's joining us, who's been very patiently waiting. Anne Webster, are you there with your question?
Is that okay? Can you hear me?
Yes, looking good.
Okay. I've never had COVID, and I've quite a few friends who haven't had COVID. We're all over 60 and we've all had all the vaccines and boosters that we've been offered. One of my friends said to me this week, he wondered if we were therefore it would be particularly difficult for us if there was a nasty new variant that we hadn't had COVID. And I was just curious to know how you would have responded to the question.
Gosh, you've got great questions today. That's a very interesting question. Do we have any takers? I am slightly looking at Aris at the moment, but other than that, unless Aris jumps in, do we have any takers for that? Hello?
I can talk. Sorry, I've had my hand up. I can talk a little bit about this. I think this is, you're really lucky if you've not had COVID. I'm quite jealous.
And I know quite a few people who haven't.
I mean, I guess it's how confident as well that you haven't had COVID, because some people are having a very mild infection or an asymptomatic infection. So unless you're testing all the time, it's possible that you've had it and it's been, below the level of detection, because the lateral flow tests are not as sensitive as the PCR tests were. So if you've got a very low level of infection because you've got a fantastic response to the vaccines, then you might feel a little bit unwell, nothing terrible, but you won't necessarily get a positive lateral flow test. I mean, they do usually ultimately work, but there is that kind of issue. Now, there's been quite a lot of studies done that are sort of trying to understand the dynamics of infection and the dynamics of the antibody response. And I think one of the things that's been good about the vaccine schedule is that the vaccine schedule has broadened to look at sort of broader range of targets than just that original ancestral strain. And what that does is it not only boosts your primary antibody response so you can neutralize a virus, but it broadens your capacity to respond to more than one target. And this is beneficial. So it's starting to sort of resemble more that kind of picture of what we've been calling hybrid immunity. So I think if you've been taking all the vaccines and you haven't been infected, you may well have been exposed, but your antibodies are just so super that you are you're doing really well. And we will continue to develop more vaccines and continue to try and outpace this virus. And hopefully one day we'll have a completely sterilizing vaccine that means we don't have to have all these boosters. That's my hope.
Thank you very much. And sorry I missed you there, Sheena. Actually, on a related question, I'm going to jump to one of the questions here, which is about, is there any data on how much COVID we could miss by using lateral flow tests versus PCR? And what does that mean in terms of missing long COVID? Does anybody want to try their hand at that? Steve, Professor Griffin, would you like to come?
We get asked this a lot. In the early times of the pandemic, it's very clear because we didn't have the sort of stock of immunity that we had built up. So it was very clear. But then the dynamics of the virus have changed as well. But as a rule of thumb, if you were to compare PCRs with a lateral flow device at a given level of virus in someone's body, you'd probably miss about 20% of the infections that PCR would pick up that a lateral flow would not. So that's what you'd call a false negative, because you are infected. And that's why we shouldn't really be using lateral flow tests as what we would call a green light test, saying that we're definitely clear of the virus. They're always what we call a red light test. So yes, I imagine, and this isn't doubting, our last guest, Katie, wasn't negative, but it is, as Sheena said, quite possible that you miss infections. Some of them are asymptomatic. And of course, I think there will therefore be a reasonable number of people who may have developed long COVID who hadn't realized that they'd have the acute infection. There's a real trouble, especially as well in children who sometimes don't seroconvert, so don't have very severe symptoms, but of course sometimes do. And they're not tested very often. And in fact, guidance now is not to test children. And we know that children can get long COVID. And there are something over 60,000 kids living with that disorder at the moment in the UK. So there must be cases being missed. It's hard to believe that there isn't. So I think that, it's very difficult to insist that you link a test through to diagnosis. I think people need to be making diagnoses based on what's in front of them rather than older tests.
Yeah, and it raises really important questions, doesn't it, in terms of yes, certainly in terms of long COVID, I think. So it's not just a question of the fact that people aren't testing, it's also what kind of tests, and then the implications of people having long COVID and not realizing they have long COVID and not getting the necessary treatment. And I didn't get the chance to...
Sorry, Zubaida, can I just say, just one reminder, even if it says it's just for your nose, always do your throat as well as your nose, and do the throat first, obviously, because it works much better.
Important, very good reminder, very good reminder. Sorry, Anne, I just wanted to say thank you so much for that question. Excellent question, and thank you for joining us. Right, moving on really swiftly. I think we have probably time to squeeze in one or two more questions. By the way, previous question was from Aditya Narkar about lateral flow tests. Thank you, Aditya. Right, from Liz. My husband is due to have surgery. I'm extremely concerned he could be vulnerable to catching COVID in hospital. However, when I spoke to the hospital about what kind of risks, what kind of measures they would take to mitigate the risk of him getting COVID either before the surgery or after the surgery, they weren't very helpful. I'd asked to put a HEPA filter in his room. They refused. I asked if some of the team would wear a mask around him. That was unclear. I feel at the mercy of the hospital. Is there anything that you would recommend? Sorry, Liz, I'm having to shorten that question, but hopefully you get the gist. Do we have any takers, any quick takers? About masks in hospital. Sarah, would you like to come in, and then Len very quickly?
Well, I was just going to say it's such a difficult situation to be in, being the vulnerable party and having to fight your corner. So if there's anybody that you trust, that you know will argue on your behalf, and just try and get the team on side to absolutely understand your situation and I don't know, it's really hard. I just wish you all the best with it. And I really hope that you can find someone to advocate for you in that situation.
Thank you so much. Dr. Lee.
Thanks, Zubaida. A tricky question, isn't it? Because just like the public's been asked to make individual decisions, so have clinical staff too. And the strict rule across the healthcare system has changed. And one of the things I would say is that the most important people in the healthcare system, some of the most important people, are the nurses which look after you and the ward sister. And they're absolutely amazing. They have autonomy to make decisions. They're able to advocate for the patient's behalf. And so what Sarah probably worked out is actually all we need to do is maybe meet them beforehand, explain the situation in a very, just put the facts out there and say, actually, to make me feel safe based on my situation, I would like, and then see what they say, because actually the NHS is the most adaptable, wonderful organisation. Actually, it's all about individuals doing the best for their patient. And I mean, look, at the end of the day, it's a window to be open and wearing a mask. And I can't see a healthcare professional, a doctor, a nurse who's so stressed and grumpy that they wouldn't do that for their patients. I certainly would. And I think I feel reasonably positive if you can have that conversation. It's difficult when you do it by emails or telephone, because nowadays they're so busy, they just don't get time. There's just a quick response. But I think have that conversation and see if you can move them one by one, just like Sarah did.
I love those hopeful, inspiring and positive responses. Thanks so much. I really wanted to squeeze in another question, but I think we're going to struggle with it today. So I just wanted to say thank you so much. Thank you so much to our guests, Sarah, Mark and Martin, for joining us today. It was incredibly powerful to hear your lived experiences, your research, how you combined it, how you've been proactive in taking measures, not just to help yourself, but to help others. And I think that's one of the overwhelming messages about today, that measures that could be taken to help clinically vulnerable people to live fuller lives, to have the freedom that many of the rest of us enjoy, to have that same freedom on a daily basis, to be able to go into work, to be able to leave their homes, to be a bit more risk-free. Those measures would benefit everybody in society. So that's really something that we need to think about today. We also need to think about the fact that repeated infections is not good for anybody. It's not good for anybody. Repeated infections means higher likelihood of severe illnesses, higher likelihood of long COVID. Long COVID, we've still got hundreds of thousands of people struggling with long COVID and with the consequent and with the related mental and physical illnesses with that. Right. So sadly, that's all we have time for questions. Hopefully we'll be able to pick them up. Thanks to Dr. Lennard Lee for putting that session together. As I've said to our guests, for joining us today with their very valuable insights. Really appreciate you taking the time to do that. Thanks to the wonderful members of the public for joining us today, and to our amazing and lovely Independent Sage panel for being here and patiently answering the questions. A reminder, this was our second to last session, and on 1st of December, Friday, 1st of December, it will be our last public briefing. So please do tune in on that. We'll be having quite a few of our exciting former members joining us on that session, and we have a very special guest. I just want to say, it doesn't mean, even though that will be our last session on December the 1st, it doesn't mean that we're going away. It doesn't mean that the pandemic's over. It doesn't mean that we think that the pandemic is over. As you heard very powerfully today, it certainly is not. And we've seen that from the amazing data that Professor Pagel and others are sharing with us on a regular basis. So we will continue to engage. We'll be on all the social media channels, including other channels. We'll post updates and details of what's happening after December the 1st will be on Twitter. So please watch out for that. Right. Thanks for tuning in, everyone. We'll see you in 2 weeks' time. And until then, take care and keep safe. Thanks, everyone. Bye.